The presenter for Part 3 on high-quality supervision is Dr. Erica Wise, who has given an enormous amount of time and professional expertise to this project. The discussants for this section are Susan Hurt, a licensed psychologist, Christian Morrow, also a licensed psychologist, and two licensed psychological associates, Stacy Jones and Tanya Crockett-Omar. We'll now move on to section 3.
Good morning. I'm Erica Wise, and I'm delighted to spend time with you today to talk about high-quality supervision as part of this board-mandated training series. I'm also really delighted to have board members and supervision experts with us today to make this a participatory training experience. I'm going to have them introduce themselves based on the order that I see them on my screen, and then we will proceed with the training. So first, I'd like to introduce Dr. Chris Morrow.
Hello, everyone. My name is Chris Morrow. I'm a clinical psychologist and associate professor at Duke University Medical Center. I'm currently the director of the clinical psychology doctoral internship. And for over 20 years, I've been fortunate enough to supervise graduate students, interns, and postdocs, primarily in academic medical centers and training settings. So thank you for having me here today.
Thanks, Chris. And next is Dr. Susan Hurt. You're muted.
Sorry about that. I'm Susan Hurt. I'm a licensed psychologist and a board member, and I'm here in my office at Central Regional Hospital where I practice as a forensic psychologist. Supervision comes up more for me in my part-time practice when I came from a full-time private practice where I supervise licensed psychological associates and have done some supervision of provisionally licensed psychologists. And I guess I'm learning over the years how rare this is. I actually did have supervision training as part of my doctoral level training. It was at University of Virginia, and I was a clinic TA, so I was frontline supervisor for beginning psychologists, and then my supervisor was training me in principles and practices of supervision. And yeah, and I had no idea that that is apparently somewhat a little bit rare. But anyway, yep, that's me.
Thank you, Susan. And next is Ms. Tanya Crockett.
Yes, I'm Tanya. I'm Tanya Crockett-Omar. I am a licensed psychological associate, LPA. I've been in practice for about 18 years, and I have definitely utilized over the time supervision. I've had supervision the entire time, and I still have my same supervisor. So I've enjoyed the process, and I'm excited to be a part of this learning phase for the board. I'm also a board member.
Thank you. And Ms. Stacy McDonald-Jones.
Hi, I'm Stacy McDonald-Jones. I'm a licensed psychological associate and have been working for over 26 years. So I certainly have over 26 years of receiving supervision as an LPA. I'm a board member, and I provide administrative supervision to clinicians in my work at Broughton Hospital.
Great, thank you. So we're going to go ahead and get started. The presentation today will be a mix of me covering some of the concepts that I teach, that I taught for many years in a fourth-year doctoral program seminar on clinical supervision, but also a chance to discuss some of the concepts with our expert participants, and also we'll look at a couple of challenging vignettes during the course of the time. So I am a licensed psychologist also, and I've spent my career in both academic and practice settings, primarily at UNC Chapel Hill. And in contrast to what Susan Hurt mentioned, I will acknowledge up front that most of what I learned about supervision was not learned in graduate school or internship. The APA accreditation standards do now require, in a developmentally graded way, teaching and learning about methods and models of supervision, but that was definitely not the case when I trained. And for me, learning about supervision as a competency has been like taking a language course after you have lived in a country where the language is spoken. It has given constructs to better understand experiences that I had recognized but never articulated. As is the case in learning theories of psychotherapy, I believe that understanding basic supervision theory and constructs can really meaningfully improve the quality of supervision. Many supervisors believe that being an excellent therapist or having been a supervisee qualifies you to be a supervisor. As we go through this portion of the presentation, I ask you to reflect on the differences in those roles. Supervision is now recognized as a unique professional activity with its own competencies. And as I mentioned, APA accreditation standards now require this in training. So I'll start today by hitting a few highlights, but I encourage you to consider including supervision updates in your continuing professional development. I know NCPA and other professional groups have offered supervision training, and as the field develops, I think it really can improve the quality of the supervision we offer if we continue to get training. So early on, I wanted us to think together about a couple of thought questions for supervisors. So what formal supervision training have you had? As you've already heard today, among the group here, there's quite a bit of variety in what sort of training we initially had. And so again, it's a place where honest self-assessment can help you decide that you may want to do some more training. The other questions I wanted us to think about are, what did you find most helpful when you were learning to supervise? And beyond that, what supervision experiences were most helpful to you? And an area where I want us to have a little bit of discussion from our participants today is to think of a supervisor who was especially supportive and helpful to you in your own training. And what did this supervisor do? And sometimes even more importantly, what did they not do? So I'm going to turn it over to the group. And I think rather than formally raise hands, I think we're a small enough group that it's okay if you just want to kind of unmute yourself and share whatever thoughts you have about that.
Hey, Erica, this is Stacy Jones, and I was thinking a lot about this question. I have been so fortunate to have great supervisors in my career, and when I reflect back on some of the aspects that were particularly helpful to me, is the supervisor that understands that sometimes one needs to vent versus complain, but then takes that venting into a direction of how do we take that challenge that I'm expressing and moving it forward to be solution oriented to address whatever the problem it might be, whether it's an issue within the therapy or maybe a colleague issue or a differences in clinical opinion in something. So I found that to be pretty helpful. Somebody that can help me vent and then move forward.
I really love that, and something we'll be talking about a little bit later, and maybe we can kind of flesh that out together, is thinking about the importance of the therapeutic alliance and sort of what makes it feel safe enough to do that, where you have a level of trust in your supervisor that you can talk honestly about, the stresses and strains you're experiencing, which I think just about every clinical setting or organization is gonna have some of those, and they definitely impact our ability to provide good service, which of course is what this is all about. Any other comments on this question?
I also agree with Stacy. I have always enjoyed this part of supervision where you can take in the clinical issues that you have and the resources that the supervisor is able to provide. Those have been so helpful for me over the years with developing different toolkits. So I think that's super helpful to have a supervisor that is knowledgeable and able to share and add to, your repertoire of information.
Great, thank you.
Mm-hmm.
Chris or Susan?
Yeah, I can add that I think echoing some of the previous comments, having that foundation that sort of parallels the therapeutic relationship, one that's trust is the foundation, and one where you can feel vulnerable to be able to share things that you're struggling with. And having that supervisor, meet many roles. I will say I've been very fortunate, again, working in training settings to watch people supervise, and then have people watch me as a supervisee. So like getting that direct feedback, whether it's video, audio, or, I think being able to give direct feedback on how you're doing, or being able to do that as a supervisor, is invaluable as well.
Thank you.
Erica, I will add one other thing as I think about the not to do. A supervisor who is, for lack of a better word, conflict avoidant. I find that's not been helpful, that they've been, the reluctance maybe to confront a situation, maybe confront me in a situation, because they don't want to hurt my feelings, maybe. I find that's not very helpful.
Yeah, there is some literature. We're not going to really be covering that today, but that sort of looks at surveys of supervisees, especially several years outside of training. And I'm thinking more in training programs where more of this has been done, of this research, that supervisees, again, especially in training and I think beyond, really do want honest feedback and want to grow. So that notion that someone is kind of just rubber stamping whatever they do can make the supervision endeavor feel less meaningful. And we'll kind of, as we go forward, we will look at some of the elements, both within the supervisee, the supervisor, and the kind of relationship that can enable that sort of more honest communication when there's questions or concerns on either side, what makes it possible to bring those up and have that be part of the process. One thing I had not thought about really today, but I sort of want to mention, kind of in a follow-up to something Chris mentioned, is how supervision can be a space, I think, to inculcate values of self-care, both for supervising, kind of earlier. And I know this is not about supervising trainees per se, although one of the areas of board-mandated supervision are provisionally licensed psychologists who will be licensed as LPs eventually, licensed psychologists. But the idea of learning self-care in supervision, I think, is a really critical idea. And I think it can extend career long. And that's especially relevant today, looking at the stresses of 2 years of COVID and being in a, sort of on the verge of global conflicts and all of our political and sort of all the sort of unsettling events in our own country, I think has affected psychologists just as much as it's affected everyone else. And in fact, we're taking care of more stressed people. So I think that role of supervision to sort of manage and process stress and get support can be really helpful as well.
I was going to say that was actually a huge value to my supervision relationships, where the supervisor would sometimes notice and say, hey, maybe you shouldn't take this thing on, or maybe you should manage your time differently here. Let's try. So that was a huge part of my supervision, where self-care was priority. They wanted to make sure the burnout wasn't there, just really supporting me through that process.
Yeah, but I appreciate your sharing that. I think these are really great conversations to have in any setting where supervision occurs. So I appreciate that. So even though board mandated supervision is mandated, that doesn't mean it can't be genuinely meaningful. And I think we're sort of hearing about some of those elements today. And in order to teach something well, we really need to have learned it ourselves. And in fact, serving as a supervisor can enhance your own professional development, since you need to articulate how and why you do things. And supervisors really do vary on many dimensions as they follow their own developmental trajectories over time. So some of the things to think about that, generally, I think we've heard a little bit about that today, is the willingness for the supervisor to consider the perspective of the supervisee, In many settings, particularly with board mandated supervision, supervisees may have more experience than supervisors, either in general or certainly in the setting where they're working. And the ability to really think about the supervisee's needs and concerns, both individual differences, and we'll look at some of the development over time. So as a very basic definition, so why do we have supervision? And some of the folks who've written a lot about supervision, Bernard and Goodyear have a series of books. They really are expert, and they've talked about it being they called it an odd pedagogical activity, that most teaching and learning occurs, in a more formal way, where, you have an instructor or professor providing information and the students absorb it. And supervision is a much more interactive kind of process, and it's one-on-one. And I think, as already has been brought up, it has a lot of parallels to the clinical situation itself. So it is sort of interesting to think about what is supervision really and what purposes does it serve. I think the three that Bernard and Goodyear suggest kind of cover the range, and they also do get to, I think, where some of the stresses and strains can be in the role. So obviously one goal is to enhance professional functioning of the supervisee, to monitor the quality of the professional services, and in some settings and in some circumstances, gatekeeping for the board and the profession. So obviously supervision evaluations are part of anyone getting licensed, and for LPAs with the requirement for ongoing supervision, the yearly reports are part of, intended to be a quality control for the public. So we're going to look a little bit today at models of supervision, and we're not going to cover all of them, but cover a few that I think are most relevant. And understanding these models, I think, can increase both our intentionality and our engagement in supervision. Theoretical models, which I'm going to mention, but we're not going to cover in any detail, often reflect a parallel between the model of therapy or the theory of therapy and how the supervision is being provided. So as an example, I had some psychodynamic training very early on internship, but I'm definitely a CBT practitioner. But if you are a psychodynamic psychologist, your supervision might look very different than if you're a CBT therapist. So a CBT therapist might intentionally organize supervision meetings with an agenda. They might notice when core beliefs or skills on the part of the supervisee seem to be interfering with their professional development. But they also might engage in role plays if there's a new intervention or something that's really challenging. And also, for CBT therapists, tend to adhere to session start and stop times, and we'll also just look at, sort of anything that a supervisee might be wanting to work on. You would could bring it into the supervision and really work on it very intentionally. So it's kind of skills-based, but also rooted in a CBT model. So the next part we're going to look at kind of interfaces with this. So I'm going to share these, and then we're going to look a little bit about how you might bring these into your supervision. So the model, this sort of began with Bernard back in 1979. She looks at the focus of supervision. So what are you actually doing in the supervision session? So if the focus of supervision is intervention, you're looking at what sort of treatment might be most appropriate for the clinical issue that's under consideration. Conceptualization, I think is familiar to all of us. You're thinking about how might we understand this client's struggles with connecting to others or with getting their work done or whatever the presenting problem is. How do we conceptualize broadly from a, depending on your background, a developmental perspective or CBT or CBT perspective. Personalization is, I think, a very interesting one. And when supervision videos are analyzed, this tends to be one that people agree is important, but is a little harder for, say, like observers to say, okay, that's what's going on right now. But personalization is the step where you are looking at what aspects of the supervisee's personality might be interfacing with the treatment being provided. So one example might be a supervisee who's highly sensitive and has a particular struggle with causing someone any distress, might have trouble in doing exposure-based treatments, which we know are evidence-based and very helpful, but in the short run, they make people uncomfortable. So as a supervisee, that would be a great thing to bring into a supervision session to say, I know I need to be challenging the client a little bit more to sort of take some steps in our planned exposure treatment. It just makes me so uncomfortable to make them uncomfortable. So if someone can bring that in, that's kind of the personalization aspect of it. And there's actually a literature now on teaching exposure-based treatment, which actually includes working with trainees to kind of anticipate and manage their own feelings about that. And I think as we have learned a lot, especially in trauma therapy, which I'm not an expert in, I know that that's a major part of the training is how do you work with psychologists who are doing this kind of work. Social roles, I think, are also interesting. And when I first started learning about this, I had a little bit of an experience of being more aware of what I was doing than I was used to, kind of like that language analogy I used earlier. So these consider some common roles as they are enacted in supervision. So as a teacher, we might present information about a disorder or a treatment. We might, with the supervisee, look, say, if the client's on a medication, we might learn what that is and, teach or discuss, how that might affect them, learn about a disorder. Or you might ask a supervisee to research some common diagnoses or treatments. As a counselor, although we are, I'll mention a little bit, obviously, some limits to that. We might gently ask the supervisee to examine an area that they're avoiding or may need some support to address. So again, we are not ever a therapist to a supervisee, but I'm using the term counselor to sort of look at the ways in which we might address what the experience feels like to someone, what it might stir up for them. And it's not uncommon, at least in training programs, if there are areas that come up that are really distressing, to encourage someone to get some personal therapy in order to have that not get in the way of their work. So I use the word counselor in a very limited sense, just as it's relevant to being able to enact their role most effectively as a therapist or in an assessment situation. All of these apply equally to assessment. If you're someone who has trouble asking someone questions they don't want to answer, both the personalization and the counselor aspect might be a way to sensitively discuss that, because if you can't do that, you're not going to be an effective assessor. The consultant aspect is one similar to personalization that's important, but it's a little harder for people to address. And those are the times in a supervision session, and these really come out of observations and coding of supervision sessions, where if you were just to look at that clip, it wouldn't be obvious who's the supervisor and who's the supervisee. So it might be where you're engaged together and thinking collaboratively about, how do we understand? How does this make sense? Or why is this client not improving? Or why was this intervention helpful and that one wasn't? So you're sort of thinking together. And as I mentioned, I think when I first was aware of these, I would sort of notice these happening kind of organically in sessions. But I think being aware of who the supervisee is and who you are as a supervisor can sometimes help you use those roles sort of more effectively. So in this next section, we're going to look a little bit about how these intersect. Each of these, obviously, there's kind of a matrix. And since we're together, I'm really delighted that we can have a chance to kind of look at this together. And so I sort of wanted to see if our participants might have some ideas that they would be willing to share about where these might cross, some examples in their own experiences as supervisees or supervisors where this has sort of been enacted in a supervision session.
Thanks, Erica. I think this is a really nice model. And I think a first step for supervisors is to really just be mindful of the roles that they may take. And also just which ones are more comfortable. I think there's some research to support, and if you're a CBT therapist, you may prefer the teacher role in supervision that focuses on teaching a certain level of skills and intervention. Sometimes I find the easiest role is to be more of a consultant, where you're talking about conceptualization, and it's more collaborative and it feels more equal, and you're trying to figure things out together. But as Stacy said, that can sometimes be a little bit maybe conflict avoidant, where there are times where you do need to take a more therapist counselor role and address personalization, which I think are the two that are the hardest, but can often be most important. And the one example that I also do a lot of exposure therapy for anxiety. So Erica's example was spot on. Something that's been helpful for me is whenever I do get into the therapist counselor role is to sort of give a little heads up to your supervisee. I'd like to ask you about how you're feeling about this patient. And the reason why is because I don't want to be your therapist, but I think it might be impacting the work that you're doing with your client. And I think it can be really important for us to explore that. And, are you willing to do that? And so a little bit of an informed consent when you're going into that kind of role, and the purpose and reason for why you're doing it, I think can be incredibly helpful. So those are just some comments of how I've been mindful and have found the model to be helpful. And I think it's important to try to be flexible for yourself as supervisor, but also to meet the supervisee where they might need the most help as well.
Thank you.
Yeah, I agree with that too. And I would say combining this slide with an earlier slide about, to quote that, meeting the supervisees where they are. All of the people that I currently supervise are highly, highly experienced practitioners. And I'm trying to think if all of them have been practicing longer than I have. And I think maybe they have. And I would say that we spend almost all of our time if I put an X on here, it would be the consultant conceptualization box, just almost all of the time. And usually what happens in our supervision sessions, and also I was just thinking the sessions are different among supervisees, and I think the tone and pace and how we do it comes from them as well. It probably should. But the word that comes up is brainstorming, because most of the time we're not even addressing anything like, are you on the right track, or is the skill set there, or do you know what to do with these clients? I think they're using supervision to brainstorm anything that might additionally be helpful. So I would say with very experienced people, and we used to meet monthly and now we're eating quarterly. So the person, but I think with very experienced supervisees, we're more likely to be at that consultant conceptualization square.
Yeah, I love that, because you're really capturing, I think, the developmental arc that can occur. So I think that's really great. And I like the idea of, as Chris mentioned, of sort of giving a heads up if you think you might be moving into an area that's a little bit more of a personalization area, or where you're a little bit more of a counselor, and really tying it to what's needed to be effective as a therapist. I mean, that's really what you're supposed to be about, not people's purely personal separate life, but what intersects with their role as a therapist.
And typically that happens early on in supervision when it's a newer clinician, because I remember that phase where the supervision, like I said, I've had the same supervisor for years, but I remember the phase when the supervision was about, okay, it's the teaching mode, so that would probably have been more of the teaching, intervention, and personalization, all of it together, honestly, because I'm newer. And I remember it progressing to where now it definitely is more of the brainstorming, as Susan was saying, consulting, conceptualization. Yeah.
And I can remember in that middle stage where my supervisor knew me very well, and may guide me to say, you know, Stacy, I know that you have rescuer tendencies.
Yes.
So look at that and and how you're working with this individual client. And so kind of recognizing where I could potentially get into some pitfalls based upon kind of who I am.
That's right.
I think that can be so helpful, and it does take having some foundation of trust and respect, you know, around the boundaries and limits to how you talk about that, so that the supervisee experiences that as supportive and not threatening or undermining. So we're going to look a little, any other more comments on this? Okay. Yeah, so I think this will be sort of fun to keep in mind as we go ahead and as we look at some of the vignettes coming up as well. And so I think pulling this together a little bit, these are a couple of big takeaways from development, sort of from a broader developmental model, that supervisees recognize predictable stages as their supervisees gain experience, that they provide more structure and direction at the beginning and less with more experience. And I like that idea, which I had not really thought about prior, is that shift from you know, to sort of maybe that more conceptualization and consultant focus would sort of occur more over time. And that, yeah, and again, that these social roles may shift. I sort of think of the developmental model as in some ways being kind of a fourth dimension to the social role and the focus considerations, like how each of those sort of look over time. I know in my own experience, I had started with supervising psychiatry residents and then more advanced graduate students and interns, and then moved in my program to teaching and supervising second-year graduate students. And I got some pretty honest feedback, which was a little, you know, challenging at the time, but really helped me, which was that I love to conceptualize. And so second-year students would say, well, you know, Erica, she loves to talk about cases and thinking about ideas, but we don't know what to say when we go in the room. We don't know how to start a session. We don't know how to end a session. I really need more concrete assistance. So I got that feedback, and it really helped me learn that I needed to spend more time in a teaching role and being very concrete and specific, because if people, you know, it's sort of like a hierarchy of needs. If you don't know the basics, you're not going to be effective, you know, in thinking about sort of higher order conceptualization. So, you know, sometimes we learn those lessons in harder ways. But I think that maybe the fact that I was approachable enough helped people feel safe to tell me. So that was a good thing. All right. We're going to move on and talk a little bit about the supervisory alliance and why that's important. There's a pretty robust literature on this. Most of it was sort of built on the literature on therapeutic alliance using the working alliance inventory. So I think supervision is really best conceptualized as a triadic system. And, you know, where in most cases, in most settings, the client and the supervisor have no direct relationship. The supervisee kind of mediates the connection. And so any influence that you're going to have really as a supervisor will be kind of via the supervisee who's actually treating the client. And that's one reason it's really, really important, because as a supervisor, you're kind of the supervisee is really the pivot point in this. And I sort of ask you to keep this in mind as we sort of look at the next couple of concepts we're going to be talking about. So again, this is really in supervision what we're working with. And I think we've started to look at some of the elements of the working alliance, you know, how it kind of comes into life. But sort of now we're going to look at it as a sort of concept of its own right. So these are considered to be the elements of the working alliance: agreement on tasks and bonds and goals. Again, this is drawn directly from the therapeutic treatment literature, looking at the relationship between therapists and clients or patients. So it's commonly believed that that it's primarily the supervisor's responsibility because, even in long-term supervision, there is still, again, in kind of a literature sense, technically a power difference between the supervisor and supervisee. And so it falls primarily on the supervisor, but I think over time, it becomes a much greater, much more of a shared responsibility over time. And the higher alliances have been associated with greater internalizing of what's learned in supervision and better adherence to treatment and improved outcome for patients and clients as well. So how do we do this? What are some of the ways we can make this happen? So we can create shared goals with our supervisee. And I try to do that in, with supervisees who are kind of newer to the experience by asking them what they want to get out of it. And sometimes that stumps people. It's like, well, we just have to do it. So what do you mean, what do I want to get out? What I want to get out of it is that we're following the rules. But I think if we can think beyond that, like, what do you want to work on? What are your skills? What are your personal goals as a therapist? And I hope that all of us as professionals always have these, but I think in supervision, it's a really helpful place to articulate that and use that. So, for example, I think we've, sort of talked a little bit about maybe using in practice around how to kind of set limits, how to be really effective and take care of yourself. I know earlier in training, therapists may have a lot of difficulty with knowing that they can set limits. They might take on doing a lot of work if there's something that needs to be like resources to check on, that it can really be better sometimes for clients to do some of that and be more empowering. But if you're someone who likes to take everything on yourself, you may need some gentle reminder to kind of stand back. Some of the other, that to sort of clarify structure and process of supervision can really help so people know what they're doing and what's expected. Discussing mutual expectations, what do we each bring to this? It's not required per se in North Carolina, but it has become more common to have a supervision contract. And I don't mean the one that gets notarized and submitted to the board, but more of a contract around like, I will come on time and I will bring up the issues that are important to me, and sort of like more of a contract about how the supervision will occur and whose roles and responsibilities and what they are. Inviting questions and feedback, and also openly discussing evaluations and ratings. I think the comments that several people have made about being conflict adverse, if there is something that a supervisor or supervisee is concerned about, it can be really hard to bring that up, but I also think that's the best way to try to improve the relationship. Any comments on any of this material before we move on?
I would just say that, I'm sorry, go ahead, Susan.
Well, I was just going to say, I think it's kind of important to acknowledge here that a lot of people getting board mandated supervision are getting board mandated supervision because it's mandated. And I think if the legislature were to cease requiring these sessions, some people would just stop having them. And it's just important to acknowledge in terms of goals or interests in having supervision that some people might be leaving the 1 hour supervision session not really expecting to do anything differently and think that they would be fine without it too. And it can just have an effect on the alliance if people really don't want to be there, don't feel they should need to be there, don't feel it's a valid requirement in the first place. And I think in most relationships, you get around that. You don't waste your time, you spend your time, and who doesn't benefit from consultation with another, practicing person. But in terms of forming the alliance, it might not be the same goals over time as in the beginning. It might just be to meet the regulatory requirement.
I was going to say that as a supervisee, all of this provides an environment of safety. to discuss whatever needs to be discussed, even those things that might be uncomfortable, or where I know my supervisor and I might have a somewhat different opinion or approach. And as someone who's had supervision for 26 years, I appreciate what Dr. Hurt is saying, and recognizing within this, I think we can recognize the value of supervision to someone like me who has a lot of experience as a clinician, yet sees the value of this supervisor relationship more as a consulting mode, I'm sure. But every once in a while, certainly something comes up, and I'm glad to have someone there that in essence is helping me to catch my back, you know.
Thank you. Chris, did you want to?
I was just going to add that I think a supervision contract is a nice way to sort of articulate the expectations from both ways, and just also have some nice logistical accountability of like, here's how to reach me, here's when we're going to meet, here's you know, how we're gonna do that, just to provide some of that structure for some of the tasks that you're going to be doing.
Yeah, and I think, you know, I'm glad, you know, that we're bringing up also, you know, some of the, that there is a the challenge in board mandated supervision, and I think pulling all of that together is right now there is a clear requirement, and I think as supervisees, particularly LPAs who are very experienced, given the current context, it is required. So how to make that useful? And I see that as a bit of its own dialectic that we can, you know, maybe recognize and even directly talk about how that may, you know, feel professionally frustrating. At the same time, that doesn't mean that it can't be beneficial. And in fact, I think the field is moving really strongly towards recognizing the idea of sort of lifelong peer consultation and a more communitarian sort of ethic, which is something that, you know, kind of outside of this topic, I'm personally very interested in. That professional isolation is a tremendous risk factor for ethical and legal problems. And so in some ways, the current structure of mandated supervision may not be the way it will look going into the future. But I think as psychologists, if we're not embedded and don't have routine ways that we discuss and process cases, I think it's likely that we're not engaging in best practice, and I think it's going to be something increasingly expected of us in the future. So, you know, so I see that as that may be how things sort of eventually move forward. But I appreciate people's honesty about how that, you know, the kind of current situation and the stresses and strains. And so some of the benefits here, and I think these people have already addressed these, so it's just to kind of underline this, that when there is a strong alliance, the supervisees will tend to be more honest about areas of concern. They'll address negative experiences that have occurred. I've occasionally had supervisees say, I really didn't like when you said that, or that really wasn't helpful, or I asked a question and you've talked about everything but what I asked, and now we're at the end and that's frustrating. There is a burgeoning research that raising multicultural issues is more possible when you have a good alliance. As I mentioned, more likely to follow treatment plans and connect better with their clients. So lots of important benefits. So I'm going to kind of go through these a little bit more quickly, because this is just kind of some of the research on this, that there are some styles that predict working alliance better, and that for alliance, if you spend a lot of your time in the teaching role, it's probably not going to be as beneficial to your alliance. That power can be positively related to the working alliance as long as it's used benevolently, and that trainees really appreciate self-disclosure. And I think it supports the working alliance, but that it has to be developmentally appropriate. And I actually underline limited. So in my own experience in training, I had supervisors who would spend the whole time talking about themselves and their experiences. And I think that the benefit of that was a diminishing returns. But supervisees, especially, and we'll look at this in a second, if someone has made a mistake or had something happen that feels difficult, hearing that someone you respect has had a similar experience can be incredibly helpful for one's own self-compassion and acceptance that we're all, kind of on a growth trajectory. And unethical behavior obviously undermines working alliance. And there have been some surveys where trainees do report unethical behavior on part of their supervisors. So these are some of the supervisee factors that influence alliance. Negative experience with supervision. So it's always a good chance for the supervisee to ask, what has been your prior experience? And that's a great question to ask a client or patient. Stress or anxiety, strong coping skills help, and role conflicts and ambiguity. So if it's not really clear, I think Chris mentioned a supervision contract, like what is it that we're doing? How will I get feedback? When will I get feedback? All of those things really improve alliance. Power can be sort of viewed pejoratively, and especially in relation to mutuality and unconditional positive regard. But it really should be clearly stated and used to benefit and support learning. Some of the positive qualities related to perception of power, expertness. In social psychology, they consider attractiveness to be perceived similarity in values and trustworthy, and then cultural considerations. So the ability to talk about cultural differences and sort of where we're located in an intersectionality sort of way on various cultural dimensions. And we'll look at that a little bit more. So what are some challenges and strategies? So supervisee resistance. And I'm going to sort of share some of the findings on this, but then talk about some of the kind of caveats or ways to balance thinking about it. So early supervisees, and in terms of board mandated supervision, it's typically going to be applicants, provisionally licensed psychologists, and I apologize for the acronym, early career psychologists, early career LPAs are going to usually be early supervisees who may withhold information. It may be because they're intentionally withholding it, or they may just not know what's most important, and there may be a lack of follow-through on recommendations. Later supervisees may be sort of more likely to, you may become kind of friends and you want to talk about other things and catching up and over-focus on success and under-focus challenges, and also not follow through on recommendations. And these are some of these supervisor contributions to barriers, which I think is what I really want to focus on a little bit more today. So I think as a supervisor, we may have a lack of clarity in what we are recommending. And sometimes it's because we're not communicating clearly, and sometimes it's because we're not sure. And I think it's helpful to let a supervisee know when we're not sure, and even think together and maybe model how we can get more information. Let's say, thinking about the exposure sort of paradigm, you run into some sort of difficulty and things are not working. I think it's okay to model, I don't really know, let's talk to someone who has more expertise in this and get some input. As supervisors, we may not follow through on past discussions, and we'll talk a little bit about how to help that be less likely to happen. We may also have had a stressful day and we just sort of want to chat with somebody who we like and catch up on things. The fourth one here is one that there has been some research on, and I think it's a really interesting one. It's the failure as a supervisor to distinguish between what's a must and a can intervention. So if you do a lot of sort of conceptualizing and thinking kind of generally about what might be going on, it may not be clear to a supervisee when there's a situation where you think there's something that really must happen. In my experience, and again, this is working with trainees, not with LPA supervisees, I may tell a supervisee that they really need to talk with the client about the fact that they're coming late to every session. And the supervisee may either feel uncomfortable about doing that, likely the case, and may not quite know how to do it. So I may, in watching videos, see that continues to happen. And then having the discussion, say, no, this has to be discussed, and how can we do that? or it might be around risk management issues that you really need to get a better history of recent self-harm or potential thoughts of harm to others. So I think as a supervisor, anytime you think there's something that really has to happen because it's essential clinically or it is a risk management issue, to be really clear about that. And I think we are sometimes not as clear as we think we are, and then we're surprised when something doesn't happen. Any thoughts about that before we move on? Does that kind of resonate with people?
I think it's just very interesting, the context in which we might learn supervision, which might be and now it's a required profession-wide competency in graduate school and internship, versus then how is it practiced? And this is why it's nice, the diversity in the panel, in terms of like, you know, I'm in a training setting, and you know, Tanya and Stacey are in practice setting, and Susan has been, you know, supervising folks with 20 years plus experience. And there's definitely like a different context in like how a must versus can. And also the nature of the supervision is a little bit different in terms of like who's responsible for the case. Whereas with it's a trainee, I'm responsible for the case. So if they need to assess safety, this is something they have to do, versus where like an LPA and LP relationship is a little bit different in terms of who's responsible for the case. And so I do think it's very interesting to understand those contexts as we think about how the literature of supervision is written, and then also how it's practiced in reality in our state. And I'm learning as I'm listening to this talk, and enjoying and appreciating the differences there.
Yeah, and I would add to that, I don't know that this is necessarily in the context of it's not in the context of resistance at all, and maybe not even barriers, but picking up on how things change with people they're out practice, they're not training, they're practicing, they have their own caseload, they have their own business. And some of the issues that come up are not about individual clients. Like where I was practicing, our LME broke up and set the requirement for the need for new contracts for Medicaid-based care. That comes up in supervision, like how is that going to go? What are we going to do? Caseload issues, or sometimes the supervisee is considering a new contract with an agency, and the supervisor has had that kind of contract before. That can come up in supervision. So the practice-based supervision is not always case consultation. I mean, it's wide open. But then that also kind of puts you on the course of a line drawing exercise, because then if you're starting to talk about how is practice going, how is the caseload going, you know, where do you draw the line on what's actually kind of staying and what's expected for supervision versus how are we doing and how is it going and what have you. But it's a broader base to start, yeah.
In that same arena, Susan, that you're talking about, for me, with my supervisor, it became a conversation of understanding when you're out practicing privately or by yourself, how do you maintain all the ethics? So we would have a lot of conversations on the ethics and the what to know about being a professional out by yourself. Does that make sense? Yeah, okay.
Yeah, so especially with a much more experienced supervisee, there may be very few sort of must interventions that a supervisor would make. And I also hear some of the conversations may shift to thinking about sort of more meta or agency level issues, like what allows you to practice in a kind of in the most ethical and effective sort of way, given the constraints of, you know, complex situations that you're in. So yeah, that's great. Okay. All right. So we'll look at this kind of briefly, because these are some ideas from where most of the literature is on trainees, but how we might at least think about this with earlier, with provisionally licensed psychologists and LPAs who are less experienced. So looking at some of the impacts of anxiety about supervision and how it can affect engagement and learning and performance. I think that's where supervisors can normalize the experience, give permission to make mistakes, and an appropriate level of sharing about your own past mistakes. So again, I've heard both graduate students and early career psychologists talk with great emotion about how very helpful it is to know that a supervisor struggled with some similar issues. That can just be really, really powerful. So organizing the supervision experience. And I don't know, I think maybe now for many of us, we have a kind of digital equivalent of this. Depends on how that looks in your setting. But I think there are 5 common causes of disorganization. Again, this is from the literature. Failing to clarify expectations, standards, and accountability, assessing supervisees' needs, failing to be adequately prepared, and failing to provide purposeful continuity. So which of these are most relevant will vary based on your setting and based on the level of expertise of the supervisor and level of experience of the supervisee. But when I reviewed this, it kind of made me very intentionally, when I got ready for supervision sessions, not to be sitting at my desk doing something else until the very moment someone came in, but to actually take a few minutes to sort of, however it is you keep track of cases you're discussing, sort of get those out, familiarize yourself with where you left off, with what things you want to follow up on. And I think that last one about continuity is really important. And I think especially for supervision with more experienced LPAs who are coming in monthly or quarterly, it would be really important for both parties to kind of take a moment to reflect on what they've last talked about, what the higher order needs are, what's most important, because meeting for an hour, that time can go really quickly. And I think you want to use it well and again, have continuity with what you're working on. I think, again, setting clear responsibilities. I think we've already heard, I think Stacy mentioned she is an administrative supervisor in her setting, and it's not unusual to have both roles. And you may need to, sort of advocate in your setting for sufficient supervision. In some settings, because it's not direct client service, and if they're benchmarking, how many providers and how much services is provided, supervision may not be highly ranked as important. So how do you coordinate that and achieve the goals of both of the organization and of the supervision? I also think when I said administrative roles and tasks, in the last bullet, I meant related to the supervision for the board. So, the board, and you will have heard about that already in the earlier presentations today. There are very clear tasks that the board requires, and treating them as if they're a hassle, which they may indeed be, but they are important and have to be taken seriously. So I think we can communicate that in how we organize the supervision. I think it's helpful to have a plan, that's appropriate for the level of experience, the caseload, what are you doing, what's your approach, have I created structure? So these are some things that I encourage supervisors to have in mind. So this is just kind of reinforcing what we've talked about. So what are some ethical standards and decision-making in supervision? I'm going to just review, I know you all have seen these and are familiar with them, but just to make sure that we're kind of have the same concepts in mind, I've pulled out a few that I think are especially relevant to supervision from the APA Ethics Code. And as a reminder, and these are kind of our sources of guidance. There's the Practice Act, the statutes, and the Code of Conduct and the rules, HIPAA, the APA Ethics Code, your institution or agency, and then there are a lot of guidelines and best practices documents. I think this is why I find ethical challenges and dilemmas to be so fascinating, because all of these different lenses are relevant. And as a reminder, the current APA Ethics Code, which is currently under revision, but if you're in North Carolina, even if you're not an APA member, it is incorporated by reference into the North Carolina Psychology Practice Act. So these are kind of the inherent challenges, and I think we've sort of looked at these already in our discussion, but there's a fee structure, accountability, which works in both directions. And I think pressure not to address problems in competence. I'm a little more familiar with this in academic settings, but it's, it's always easier to sort of not have conflict and sort of have both parties say the supervision's great, the treatment's great, everything's going fine. And so when there are problems, it's hard to address them, and that takes some courage to do that. These are considered to be common ethical issues: competence and client welfare, confidentiality, evaluation process, supervisee rights, and the relationship. So we'll just look at a couple of these and then talk about them in the context of a few vignettes.
Perfect. Can I ask a question about that slide? I just wanted to ask a quick question about confidentiality as an ethical issue in supervision, because my mind went in two directions when I saw that. And one was, if the supervisor learns confidential information and then discloses it, obvious, just don't do that. Like, that's kind of easy and ordinary. But is there an issue of breaching confidentiality between the supervisee and supervisor in supervision? Because I was wondering if there are, like in the literature, does a supervisee have limits on what they can disclose without breaching confidentiality in supervision? Because I'm not sure. Yeah, like, what is the issue of confidentiality in the context of supervision? Like, how are people having ethical problems with that?
Oh, okay. Well, I think what they mean, I think what this means in the ethics code is that you are clear about that. You may have another question in mind, but so I think it's important that as a supervisor, you keep all of the information you get that's clinical information confidential. Now, in board mandated supervision with a more advanced LPA, you may not necessarily know the names of the clients or have a lot of identifiable information. I imagine is set up differently depending on what the context is. For sure, in training programs, since as Chris mentioned, they really are, you are really responsible for the case. You will certainly know the name and you'll be signing notes and records, which is not the case with LPAs. But I think the confidentiality also can come up where supervisees may not know how confidential it is, what they're talking about. So if they talk about something in a training program, will that show up in a faculty meeting, something that they're struggling with? In a supervision, in board mandated supervision, will something go into their supervision report that gets sent to the board that they didn't know was going to be shared? So I think it's helpful to have parameters, and I have some thoughts about all of those, but maybe we can look at that in the course of a vignette. Does that sort of make sense? Okay. So I think important to be clear and to understand, and I think it's not, we sometimes launch in without really clarifying that. So I'm going to briefly share, this is the CPA Ethical Decision-Making Model, Canadian Psychological Association. I think our new APA decision-making model, there probably will be one in the ethics in our new ethics code. There is not currently, and I think it's going to look more like this. And I'm not going to read these through, but I just want you to get a flavor of this, which is that it has it's much more embedded in thinking about both multicultural issues and personal biases and who's impacted beyond just a therapist and client. So I think what we're going to see is a much broader contextual sort of ethical decision-making model coming forward. And this is not all there is. Then these are the last few aspects of it. What I will focus on a little bit as you're looking at these is number 9, which is when there is a consequence that causes harm, this ethics code actually enjoins psychologists to prevent future occurrences. So if there's something that happens out of an ethical dilemma that you think causes harm, maybe a requirement to release information or something that disadvantages someone who is say in a vulnerable role, that you would actually be asked to prevent that happening in the future. So that's a pretty high level of ethical decision-making. So we just look at a couple of the most relevant standards and then get to our first vignette. So under boundary of competence, it reminds us that we provide services, teach, conduct research, etc., only within areas of competence based on our training and our professional experience, etc. And so it just reminded us to think about that. All right, so our panel is going to discuss the vignette. They've had a chance to review it, and we'll now have a chance to discuss it.
Yeah, so this vignette raised issues for me kind of coming from maybe different directions. And one, I would say from a practical perspective, if we're supervising experienced LPAs or people in broad-based private practice, they will be doing things that we don't do. Like, for example, supervisees can be trained in highly specialized measures that we don't use. And it's necessarily true because they're, for the most part, they're going to have one board mandated supervisor for their practice, and it's not possible to find one supervisor that, you know, in terms of a Venn diagram, does 100% of what you do and nothing else, and you don't do anything else. And, you know, I think that I think it's fine. I think if the supervisee is doing a lot of assessment and the supervisor has some, you know, expertise in assessment, it's okay that additional measures are involved. And then it becomes a line drawing exercise. From the other side, you know, what is raised for me is that, I mean, we know from our general ethics code and standards of practice and our general approach that if you are going to branch out into a whole new area of practice, you need, like it says, continuing education, and you need peer consultation pretty much at the level of mentoring, and especially with high conflict custody cases, so highly specialized, so complex. But I would also say that if Dr. A could be the best expert in the state in high conflict custody cases, but if you're meeting, you know, a high conflict custody case can take, say, 3 to 6 months maybe. So if you're meeting for 1 hour in 3 months and 1 hour in 6 months, that is not going to meet the requirements of what you need for your mentoring and supervision anyway. So it's just really, it's kind of problematic from that point of view too. And it doesn't really say what else Miss B is doing. She's had continuing education. It doesn't say if she has a mentor in that field that's in addition. I just don't think board mandated supervision meets the requirements of this type of expansion of your practice, even if the board mandated supervisor is the type of expert you're looking for. It's not going to be enough.
One of the things that I noticed was what Stacey was talking about earlier, and I'm not sure why there's not enough confidence or in the relationship where she could talk about, hey, you've not done this before, and what's the plan? You know what I mean? So I just think there should be more conversation and confidence to say, I'm just worried about the testifying part of this in court, and you're non-experienced with custody cases. You can't, the part of supervision is to say that. So like Stacey said, she doesn't want anybody to just give stamps on everything. We got to just, you know, talk it out and see what's really the liability here.
I think Tanya captured exactly what my concern is with this. The statement that Dr. A decides to not mention this to Miss B since she is concerned that Miss B would lose confidence in her as a supervisor. That really speaks to me of a challenge that my supervisor is having, that they are now putting onto our supervisor relationship. And I'm counting on that supervisory relationship to help me, you know, work through and look at how I'm practicing. So in this vignette, that is probably the most concerning sentence to me as a supervisee.
I agree completely with that, Stacey, and I think there's a real lost opportunity of modeling and professional development for Dr. A to say, oh, I'm so excited that you're learning and branching out in this area, and that is beyond the scope of my competency. How can we figure out how to get you the best help that you need to become the professional that you need to be? So, you know, this also speaks again and to the difference of context of supervision in training and supervision of an LPA, where I would think supervision in training is more about monitoring the professional services as part of the definition, whereas supervision in this context of an LPA is more of like gatekeeper for the board and the profession. And I can imagine, and Susan, I'd be interested in your take on this, where like a reasonable response would be on the supervision record documenting how the LPA is making great strides in seeking consultation to acquire the necessary competencies in this new developed area, but doesn't necessarily have to be the person who is expert in that area.
Yeah, I think I mean, I would say if you're looking at it from Dr. A's role as the board mandated supervisor, that person might not be the mentor for this new kind of practice. That person would be making sure that the practitioner is getting what's required for that new type of practice. And I have had one, as the supervisor, one experience where, so I have supervised people who use specialized measures that I don't use, and we go with the, you know, kind of, I mean, I know assessment, I know how norms work, I know what they're doing, but I did have one person who was doing something that I just am not trained in and don't do and cannot extrapolate from what I do, just cannot do it. And that person had to have a second supervisor for that set of clients, and I couldn't do. And again, it's like where to draw that line. And even that, as people get more experienced, comes from consultation. Like you can jointly kind of agree, where am I going to draw the line on what it's fair to say that I qualify as your board mandated supervisor on this.
Yeah, this is a great discussion, because I think there is its own trajectory, sort of following up on what several people have said, that I think in training supervision with someone who's really inexperienced, and I think that would apply to a provisionally licensed psychologist or a beginning LPA. I think it's risky to supervise activities that you cannot do yourself. That's probably the strictest standard. But I think as an LPA is more experienced and may, through appropriate training and professional development, be engaged in activities that the LP either does not or could not offer themselves, becomes more appropriate. And that there may become sort of a fork in the road where maybe this relationship had been going perfectly well for 20 years, but at this point where Ms. B, the LPA, decides to take on something more specialized, I think the Dr. A's way to work with this is really pretty indefensible and could create a lot of problems. So it might be that it would all go smoothly, but if it didn't, and I think this is an area that's higher risk for complaints, I think Dr. A could very well be held to account for taking this on as a supervisor. And the idea of not sharing something because someone might lose confidence is both terrible professional modeling, but also a missed opportunity where, if handled well, Dr. A could really talk that through together. I don't want to learn anything about this and I can't practice this, so we'll need to discuss finding either a different supervisor for your practice or getting the kinds of input you will need for that to work, whether it's formal supervision or a different contract, or deciding that, that it's not that important to Ms. B, or that Dr. A is going to get up to speed. So some sort of resolution, but I think where it's left now, to me, feels like it's certainly not a defensible way to go.
You know, I agree with you, and I think to a certain extent this vignette really raises the ante by making it high conflict custody cases, because nobody in their right mind should be mixing or messing with that. And again, there are places on this continuum though that are a little different. And for example, if you're an LP, and I think we have to keep in mind too that everybody's not in the triangle. People are working in smaller communities and smaller towns. And now that we're using more people have the luxury of finding specialized supervisors wherever they want to go. But it didn't used to be that way. So there are a lot of moving parts to this. But just as a kind of same issue, but not high conflict custody cases. So if you have an LP who has a child assessment practice, expert in child psychopathology, expert in child assessment, whatever, and then they're supervising someone who works in a school setting, and the school setting advocates different measures than the one the private practitioner uses, can you go ahead and be the board mandated supervisor for that? And I think you could argue yes, because that's not high conflict custody cases for somebody who doesn't work in high conflict custody. You know, it's a whole continuum, because there are, among the moving parts, there are practical demands that Ms. B, she might want to take on part of her practice where 10 hours a week are child custody, but the other 30 hours a week might be something that the person who does child custody doesn't do. And then another 10 hours might be something that neither of them do, and it's just not going to work. She's going to have board mandated supervision with somebody who's the best fit possible, and get on with it.
So I think, you know, a knowledge of the board rules and also a willingness to be honest and upfront about both our areas of expertise and our limits is at least a foundation for having a conversation. So yeah, so I think, and I certainly agree, you all picked up right away on the area to be most concerned about, because if we're not honest about our competence, then we can't even really have these conversations in a meaningful way. So thank you. Okay, so we're going to look next at the standard on multiple relationships. This is an excerpt, and I've highlighted, so this was an emphasis added by me, that whenever there are questions about multiple relationships, the way that this is written provides a really nice process to go through in thinking about it. So if this relationship would reasonably be expected to impair the psychologist's objectivity, competence, or effectiveness, or if it otherwise risks exploitation, then it is considered to be one that you would not enter into, and that multiple relationships that would not reasonably be expected to cause impairment or risk exploitation or harm are not unethical. So, so this is the vignette that we've called complex relationships, and we'll give everyone a few minutes to read it, and then we'll look at a couple of questions that we've come up with for our panel to discuss.
You know, I think this vignette actually sort of goes back to Susan's question regarding confidentiality.
It does.
You know, we talked about confidentiality of patients and how much we're sharing or whatever, but this sort of alludes to that there.
Let me go to the questions page, and then we can sort of have our discussion. Does that sound okay? So these are the questions that our panel is going to discuss, and they can also, bring up anything else that they want to about this vignette.
Now, Erica, you had shared with us that you had an early question about whether the identity of the supervisor should have been disclosed to the clients, who would have also known if something was going on. And do you want to address that question of whether the supervisees should or must disclose the identity of their supervisor to clients and kind of how that works.
I think
I don't know if that's a question that would come up for a lot of people. Because I would say, I think our rules leave it, it's discretionary, and it's for the supervisee and supervisor to jointly agree how to handle all issues related to that. Identifying the supervisor, if clients want to contact the supervisor, what will happen in supervision, it's discretionary. But when something's discretionary, then it raises the question of, well, should you? You can do, and and I can see reading this vignette, one benefit of that disclosure might be that clients will know if they know the supervisor, and they might have something to say about whether their confidential information from therapy goes to that supervisor. So that might be one benefit. I can think of non-benefit things that are not beneficial about we have so much loaded into our intake sessions already, and identifying other people and practice considerations can become burdensome to clients in a way that's not about their therapy. So I could do kind of pros and cons, but the problem in this vignette would have been prevented by the clients knowing where their confidential information was going from the get-go.
Right.
But is there a reason why they had to have the specifics revealed? Because it could have just been a couple that they're counseling on versus being that clear and specific on their name, where they work. I would not do that, especially in a community where we're all in the same place. But that might become an issue if there was ever anything, I don't know, if there was ever a case of some type, then you would then have to know the supervisor.
Yeah.
I
would say in smaller communities, this is a common issue.
Yes.
Because somebody might be the principal of
Yeah.
the local high school, and it just, you don't mean it to identify, but it just comes up. And sometimes even what the kids are involved in, and like, a parent whose kids have their kids involved in the
That's
same
right.
thing, and it starts to kind of lower the, reduce the odds, increase the odds, whatever, of knowing who you're talking about.
Yeah, I think, it would be an interesting question whether it's common practice, but I don't think that most LPAs typically tell every client the name of their supervisor, and that is a major difference in the APA Ethics Code. If someone is a trainee, you do need to know the name of the supervisor, and there should be a clear way that happens, but I don't think that's true in the community. And I think these kinds of situations can happen very unintentionally. In a slightly different context, I had a consult years ago from was a licensed psychologist who was returning a call to a client who then realized, they knew that their client was a kindergarten teacher and called them back at work. And it turned out it was going to be the small school where their child was going to begin kindergarten the next year. So all of a sudden, they just didn't expect that. And there was sort of an intersection. So you might be hearing about a couple like this for a long time, and then something that's just kind of an extraneous fact connects it for you that you didn't realize it. So did you all have any sense if this occurred? Do you all think this is a harmful multiple relationship? What should the supervisor do in this case? That's maybe really the question. Because at this point, the supervisee is not aware.
Right. So it is a multiple, if you do the two-step process in the ethics code, A, is it a multiple relationship? And B, is it a multiple relationship that's an ethical problem? It is a multiple relationship, and the proof is in the pudding, because the supervisor just became uncomfortable hearing details about a different relationship. She's in one context, it's professional, and from a different context, it's making her uncomfortable. So it is a multiple relationship. And then going through the risk, it's not exploitative. Presumably the client's confidentiality isn't at risk. The supervisor will take responsibility for that. And then, the vignette kind of points to difficulty in compartmentalizing for the supervisor. Yeah. And I think it's a problem that it just came up and the supervisor's already uncomfortable. It's a dilemma what to disclose, what not to disclose, and nobody knows what the future holds, and this is only going to get worse. So it's time to address it and deal with it, I would say, yeah.
Mm-hmm. So you would tell the supervisee that you know the couple if you were the supervisor?
Yeah, I mean, as uncomfortable as that is, it's a, you know, things grow in the dark, I would say. Yeah. Things tend to grow in the dark, and they grow in directions that you can't anticipate or control. So you're better off keeping it in the light and dealing with it.
And then the couple has to know about it at that point. Is that what I'm hearing?
I don't know about that.
Okay.
I was starting with the supervisee needs to know about the issue.
Okay.
Because for one thing, the supervisee might decide on behalf of her clients to stop disclosing information to somebody who knows them personally, and the supervisee needs that option. The supervisee needs to know, I think I'm talking about confidential information in the context of therapy, but I'm disclosing it to someone who knows them outside of therapy, and it's not even known to me. Like, that's going to blow up at some point if it becomes known later. It could. It could.
I think that the supervisor certainly should tell the supervisee, but now they need to figure out how to move forward, because it's, as a supervisee, there may be things that I feel like I need to discuss with my supervisor, but now I'm acting as a gatekeeper for my client's information, and it potentially could put a supervisee, particularly someone who is not well seasoned. You know, there is a difference certainly between a trainee, a new supervisee, and someone that's got a few years under their belt. And I think it can create a difficult situation for the supervisee, because now they're not wanting to tell their supervisor something because they don't want to put their supervisor in an awkward position, yet it may be very relevant to some of the guidance they're seeking as they're processing how to work with this couple. And I think that needs to be clearly defined between the supervisee and the supervisor.
Yeah, if the supervisor says, you know, unfortunately, I can't supervise you on this case, but here's a colleague who does couples work who I think could help you, does that then LPA have to get a new supervisor contract with the board for just that one case?
Yeah, I don't know. I'd have to think about if they need a new contract. I was thinking if I were the supervisor in this situation and I said at my request, I want you to get your consultation on this case with someone else, I would also pay for it.
I thought about that.
Yeah.
I'm glad you said that, Susan, because yeah, that's relevant.
But I hadn't thought about whether a separate contract is needed. I don't know.
It is.
I don't know.
It is, because I've had to have contracts with more than one supervisor. And if it's on a case for my caseload or clinical work, that has to be.
Yeah, so I think these are really great discussions, and these are the kinds of things that even, you know, in small communities can easily happen, and even in not so small communities, I think it can come up, you know, when, as a therapist, when a client is talking about people in their life and you all of a sudden realize it's someone you know, I think that can feel really uncomfortable. But I totally agree. I think the first, you know, again, assuming here that the practice of that LPA, which I don't think is unusual at all, is to not tell every client the name of the supervisor, because that would be something that could preclude this, you know, then the clients might say, oh, I know them, or that won't work. And then you have a different, you know, have an earlier conversation. But I think the first question for the supervisor probably is, how would this impact your supervision? And if it's a place that you could say easily not go to, or, you know, sort of slightly change your practice, that could be a reasonable solution. It may depend, you know, how important that place is, how important these people are in your life, how well you know them. But I like that interim idea. You know, if you decide that continuing to go to that restaurant or this couple that you've gotten to know is really an important part of your life, then I would definitely think having a conversation with the LPA about how this would work and what the options are really are important, because if the question about it will interfere with your effectiveness if the LPA can't talk openly with you about the treatment, if you can't give them, provide supervision input in the same way you would if it was a couple you didn't know, then I think you have an impact on the quality of supervision, and can sort of think through logistics then of what do we do instead. But I could see an end of the continuum where it's a very, where it's maybe on the more remote level of contact you've had with them, and you could easily just, go to 20 other restaurants for the next 6 months and it's not a big deal, where you might even decide to keep it to yourself because you want your the LPA supervisee to feel comfortable talking with you and you feel like you can compartmentalize it. But I can easily see where that could get, easily could get awkward or get uncomfortable. And I like Susan's comment about the light of day. I mean, I would probably think carefully about keeping it to myself and how that could go wrong unless it was a more remote connection and I could easily just not be involved with them anymore.
Yeah, I think, sorry, Erica,
Go ahead.
Your first comment was, I think you mentioned, like, think of the supervisory relationship. And I would argue, like, maybe the first thought should be like, what's in the best interest of the client? Right. And, that, like, it is, and this gets to Susan's point and what others were sharing about, like, does my dual relationship or multiple relationship, will that impact how I would help them, right? And I guess it depends the nature of the relationship. Is it like an acquaintance that you go see them in a restaurant, or it's like, wow, I had no idea there was an affair, and I'm like really good friends with the wife or something? That really precludes your ability to be an effective supervisor on this case. And I think, like, recognizing that, and again, could be a learning opportunity to share, like, for the supervisee, how to model navigating ethical dilemmas and multiple roles, because it happens to all of us. It's not like, could be a really good learning. And then, like, coming up with a solution that, again, is not going to be crystal clear or a home run, but it's the best that you can do in a very difficult situation.
Thank you. Yeah, so I think maybe what they share is having, honest, having sort of some honest sort of internal conversation. This might be a great one for the supervisor to do their own consultation as well. Because once you bring it into the supervision, you've kind of shifted the dynamic at that point. So that might be a good place first to consult, which is always a good idea. But you're right. I think the most important consideration is the treatment of the client and how do you preserve that and make that as effective as you can. So a couple of we're going to kind of go through some final slides here, just from some framework that this standard in the APA Ethics Code is an interesting one because it's called student disclosure, which would not apply to LPAs, but in the actual text it says students or supervisees. So I see this as, I would argue is relevant to LPA supervision as well as supervisees. So it really looks at some limits of what psychologists can require people to share. And I think it gets to those limits of being a supervisor and not a therapist, and that we can, these are aspects that we cannot require students in training programs to share. And so I think that this should apply as a right of supervisees to have personal the ability to protect and not have to disclose their personal information. As we mentioned, and this is just what it looks like in the ethics code, that in academic and supervisory relationships, we have timely and specific processes, and we evaluate actual performance. So some of this is built into the board paperwork, but I think the second one of evaluating actual performance gets closer to what people have brought up about being that sometimes conflict aversion can make it difficult to give give honest feedback. And so I think good, that supervision is most helpful when there is honest feedback. And I think supervisees should also evaluate their supervisors. How helpful is it? What are they not covering? What are they not getting? And these are, I think, supervisee rights to competence and awareness of limits of supervisors. Humility should not be, in most cases, compelled to disclose personal information. And these are just sort of pulling these issues together in one place. I'm going to share just a couple of multicultural considerations. There is really a growing literature on this, and there have been some excellent trainings in North Carolina and nationally on multicultural supervision. So I'm just going to cover some basic concepts. I think the conversation or the term has shifted towards humility in supervision. And I think at this point, we're going to not have direct discussion of these, but these are going to be questions that I'd ask anyone watching this to sort of think for themselves about what exposure they've had, what's been helpful, what's not helpful, and how do you balance responsibility for raising multicultural considerations. I think most people who study this and write about it would say that it's primarily the responsibility of the therapist or of the supervisor to raise those issues because of the difference in power. These are some very basic concepts, and I would encourage you, if any of these are not familiar, to add this to your list of training for the future so that you learn about some, again, basic concepts in multicultural considerations. And I know that the term microaggressions has become, much more widely disseminated. I'm just gonna share a couple of thoughts about this, but I think as we think about as the path, the term has actually shifted from pipeline into psychology, but people are thinking more about pathways into psychology, of encouraging more diverse individuals in our field in order to better serve the public. That we really need to be aware not just of our clients' experiences, but also of our trainees and of our practicing psychologists. So being aware of racial microaggressions as a source of stress. Daryl Wing-Sue and his colleagues have also talked about about words or deeds that validate, support, or encourage anyone who's targeted with microaggressions. The terminology really is shifting on these considerations. Ibram Kendi, who wrote How to Be an Anti-Racist, is encouraging no longer using the term micro-intervention because he thinks it sort of minimizes the impact of these sorts of experiences. So I think we may be seeing some shift in our language. But I wanted to include this here because I think it's really, there's increased awareness, and I hope it will become more part of our discourse in supervision and training in supervision. So for new supervisees, I would really encourage supervisors to have direct conversations about aspects of personality, personal identity, cultural background that would be important for me to know about. Some of these are visible. Race or ethnicity may be visible, but many may not be. And acknowledging the impact of identities in the supervision space. So I think supervisors can share this as well. And to be humble in your own self-assessment of your knowledge, acknowledge discomfort, and also to make you aware if there are interactions in supervision that are experienced as invalidating or inappropriate. I also encourage supervisees to also feel that they can bring in experiences they have in the settings where they're working, because I think these can definitely impact ability to provide good care and distress levels. So I think that if we can make these areas of discussion, that would be really helpful to the field going forward. So I think where we need to be as effective multicultural supervision, We need to develop our critical consciousness, our own identity developments, creating safe spaces and strong working relationships, supporting supervisees, especially in regard to marginalized identities. And our cultural self should really enrich and energize supervision, not deplete it. I'm going to go through these fairly quickly, and the reason I'm including these are actually relatively recent guidelines for LPA supervision that ASPPB, which is the Association of State and Provincial Psychology Boards, approved in 2019. And as we do this, I'm hoping that we'll see that we've covered many of what they articulate as being important related to the knowledge, skills, attitudes, and values of supervisors. And I do have the link to this, and we can definitely share this with you all. In terms of the knowledge dimension, these are what ASPPB thinks are important for supervisors to know. Understanding of the professional practice being supervised. And interestingly, given our conversation, now that I look at it with fresher eyes, it doesn't say that you have to literally be able to do what's being supervised, but that you have an understanding of it. So I would see that as a gentler requirement that's kind of in line with what we've discussed. The rest of these I will let you read. I think they're fairly straightforward. These are skills. There'll be 2 slides of these. Ability to provide supervision in different modalities. In North Carolina, it's all individual is what's required, but alliance and providing feedback. I guess since we didn't cover this, formative feedback is sort of the feedback we give kind of along the way, like sort of gentle comments or sort of, ideas and suggestions versus the sorts of summative feedback that you get on an evaluation. For supervisors to self-assess and also to assess the needs of their supervisee. Oops. Being able to elicit feedback, teaching and didactics, knowing when to seek consultation, flexibility. I think these are all skills that we've either talked about or alluded to. And I'll let you take a minute to read these. I think several of these I will just highlight since we talked about them, about supervisee self-care and well-being with work demands in the settings that they're in, various competing obligations that we might experience. And I think the last 2 are of course, really important, using empirically based supervision and knowing your own limitation as a supervisor. And finally, these are some resources to consider if you have ethical dilemmas, talking with colleagues, the ethics code, the Practice Act, contacting NCPA if you're a member, contacting the North Carolina Psychology Board, or your professional liability insurance. Several of these vignettes, as we discuss them, even in this, kind of structured setting, that our expert panel really brought up issues that I had not even considered in looking at these vignettes on my own. So I think it kind of shows the power of getting people together to talk. So these are some suggested readings that can be shared through a link for anyone who's interested. But I really want to thank everyone for their kind attention, and especially our expert panel who was willing to be part of this process and bring their expertise and their experiences to sort of help bring this to life. So thank you all so much for your willingness to be here and to participate.
Thank you, Erica. And I just want to reiterate that last thing you said, the power of getting people together to talk. that's kind of what supervision is for me.
Yeah.
You know, it's very empowering, and to talk about vignettes like these or other situations that it's good to have just another voice in there. So thank you, Erica.
Yep, I
Thank
think
you.
we can get isolated in our work.